the slides? Okay, hi. Can you hear me okay? Okay, so I'm going to present like this. I'm going to present some interesting retinal cases. My presentation, it seems like a continuation of the last presentation because I am also presenting a lot of cystoid macular edema, but I think as a retina specialist, that's what we see. So uh, no financial interest. And what we are trying to learn here is some diagnostic dilemma which we face while seeing patients with intraretinal and subretinal fluid, and the importance of systemic review of the medications and the risk factors while dealing with retinal diseases, and the workup of retinal diseases which are presenting with optic disc edema. So we will, I have around 10 cases. The first case is, should this membrane be peeled or not? So this is a 90 years old male who presented in 2022, and the complaint was blurry vision left eye, which was not affecting his activities. He could read. So his vision was 20/40, and on exam, other than an epiretinal membrane, the comprehensive ophthalmologist, they thought everything was okay. There was no ARMD, so the patient was advised observation, and they were not offered the surgery given the age. Now, this patient come back a year later for his routine exam, and he says that his left eye vision is going further down. So the vision is down from 20/40 to 20/50. The ERM is still there. The thickening has become worse. And this time, the patient was offered a surgery. The patient declined because his other eye was fine. The patient came back a year later, and now the vision in the left eye is count fingers. And now the doctor refers the patient to retina because vision of count finger didn't go well with epiretinal membrane. And at this point, as we can see, the thickening has become really worse. The interesting thing is this patient did not come in between. Every time he came for his annual exam, he would be like, oh, my vision is getting worse, but he did not return sooner. Thank you. So what is the cause of macular edema here? And I just want to point out that we see that apart from the macular edema, now the patient is also starting to develop some subretinal fluid. So did we miss something here? So if we go over the history of the patient, he definitely has an epiretinal membrane, so that could be getting worse. It could be a wet macular degeneration spectrum, even though there were no drusen or pigment epithelium detachment on exam. And since the patient is pseudophakic, it could be pseudophakic macular edema, but his cataract surgery was years ago. The patient was referred to retina. He was diagnosed at wet macular degeneration and started on the anti-VEGF injections. The patient received injections for a year, every month, but his vision did not change. So a year later, after he has received like 7 or 8 injections, even though the fluid has gone down significantly, there is significant scar tissue formation, and the vision is still count finger. So is this the end of this case? Did we miss something here? So I would think of two things. First, was there a chance to save the left eye vision? And second, can we do something now for the right eye? So let's start with the left eye. Let's go back to the scans when the patient came in 2023, and at that time his vision was 20/50. So if we look at this OCT carefully, we will see that there is a small pigment epithelium detachment right next to the optic nerve head. And if we see the pattern of fluid, first of all, most of the thickening is only nasally. Even though the membrane appears diffuse, it is going in the temporal retina also. The membrane is here, but the thickening is not here. Most of the thickening is located here. And then there is a small pigment epithelium detachment. There is intraretinal fluid right next to the pigment epithelium detachment, and there is trace subretinal fluid. So this was a case of peripapillary choroidal neovascular membrane. If this patient was started on injection when his vision was 20/50, there was a chance, at least in my opinion, of saving the vision, because at that time the pigment epithelium detachment was this big. When he came a year later with count fingers vision, now we have a complete membrane, a neovascular membrane, which is going under the fovea. And that's why even after the injection, this whole membrane changed to scar tissue, and the vision could never be recovered. A diffuse subretinal hyperreflective neovascular membrane. So again, some learning points for papillary neovascular membrane. Definition-wise, they are defined as membranes located within 1 disc diameter of the nerve head. The natural course is extremely variable. There are some membranes which you monitor and they don't go to do anything. They spontaneously involute, they never come to the fovea. So not every peripapillary CNVM needs to be injected, but there are others which extend towards fovea and can cause significant vision loss. So they at least deserve monitoring, close monitoring. And then what is interesting is since the choroidal vessels can extend around the termination of Brooks membrane, so you may not see a lot of changes in the RP, which we see in a regular wet macular degeneration. So if you're seeing a small pigment epithelium detachment right next to nerve head, that is sufficient to cause significant changes. Do not ignore that. And then the second question, do we do anything for the right eye? So if you look here, the right eye looks pretty good, right? I mean, 20/20 vision, there is no edema on the scan, normal contour. But again, look carefully, go to the edges of the optic nerve head and see. And if we see carefully, in 2023, the patient in the right eye, in his good eye, had a small pigment epithelium detachment at the superior edge of the optic nerve head, which has been stable over first couple of years, but in Jan 2025, that pigment epithelium detachment started collecting some subretinal fluid. So the patient initially refused injections because this was his good eye. He's like 91 years old, but we are closely monitoring him. The SRF has stayed stable because this is a slowly progressive membrane. But at any point, if this fluid starts spreading towards macula, we have low threshold for starting to inject. But the point here is that, again, look for all areas in the macula. Just don't look at the normal contour in the center of fovea, and that's it. So that was our first case. So our second case is, what's the source of this leakage? So this is a 74-year-old male who presents with blurry vision left eye, 4 weeks. Duration, the vision is 20/40. He underwent an uneventful cataract surgery 1 year ago, and the vision, best corrected vision is at that time was 20/25. So the first scan shows his scan, how it looked a year ago. There was some epiretinal membrane, which is not so nicely seen in this scan, but he did have that. And this is current, like his vision is 20/40 for 4 weeks. And we see some new significant intraretinal fluid. And the membrane somehow also looks more prominent. So coming back to the same question, I think we missed a slide here. So coming back to the same question, what could be the causes of this cystoid macular edema? The patient was pseudophakic, but this is now a year later. Generally, the pseudophakic macular edema presents within first few months, with the peak being between 6 to 10 weeks. If it was a recent post-op, I would have considered giving him some steroid and non-steroidal eye drops to see if he improves to that. It could be macular degeneration. At least in this scan, we can see that it looks like a small pigment epithelium detachment here, but it was an artifact. He did not have one on the clinical exam. So we went over his systemic medications, and the patient did report that a few weeks ago, he was diagnosed with some new prostate problems, and he started a medication called finasteride, which is known to cause cystoid macular edema. So we gave him a trial, and we stopped the medication. And just after a month of stopping the medication, the cystoid macular edema went back to normal. And even though on this scan, the membrane looked like it was getting worse, it went back to being like what it was, very mild epiretinal membrane. So again, the point here, always review the systemic medication, especially in patients who are presenting with cystoid macular edema, because there are some of the common medications, anti-cancer medications, diabetic medications, which can cause cystoid macular edema, and just stopping the medication can solve the problem instead of going for epiretinal membrane peel or anti-VEGF injections. And then there are, I had some other cases, but in the interest of time, I'm not presenting all of them here. But there are many other conditions, especially retinal vascular occlusions, SRF or CSR-like presentations. RPE disruptions, all of these medications can cause retinal toxicity. And these days, our patients, they come with like a medication list of 30 medications. So it takes time to review all of it, but it is always worth to go over because, as I said, the disease can simply be cured by changing the patient's medications. Okay, so our case 3 is like, what are those red dots in the retina? So this is a 77-year-old male. He has a well-controlled diabetes. Last A1C was less than 6. And then he presents with blurry vision, right eye for 1 week duration. He was referred to retina for diabetic macular edema for intravitreal anti-VEGF injections. So when we look at the scans, the patient does have significant macular edema in the right eye, some edema in the left eye, and there are some red dots in the retina in both the eyes, and there is a new hemorrhage in the right eye. So what's causing this cystoid macular edema? Epiretinal membrane, well, this patient does not have one. He is phakic. So we are left with the, did I do something? Go back.
No spoilers, everyone close your eyes.
Erase the memory, yeah. Wow. I jumped like 10, 15 slides. And you know the diagnosis. Okay. This is interesting. We cannot do this. I'm still getting hang of that. Okay, so could it be diabetic or vascular occlusion? I mean, we'll need a FA, but at least in our practice, we are trying to move away from fluorescein angiography. We don't do as much of them unless and until we really need them for the diagnosis. Wet macular degeneration could cause the macular edema, but the patient didn't have any drusen, any signs of macular degeneration. And then for the other causes, we did review systemic medication. The patient didn't have any new systemic medications. So then what's the cause? So before we go for the cause of edema, we also have to remember that this patient also had a new hemorrhage in the fovea. So this is a patient who has a new bleed and worsening of macular edema, sudden onset. So we have to look for a cause which can justify both the things. So yes, macular degeneration can cause hemorrhage in the macula. Valsalva can cause retinal artery macroaneurysm, and then some bleeding disorders, but they would not cause associated cystoid macular edema. So we reviewed when the retinal specialist saw the patient on exam. Actually, instead of the microaneurysm, the patient had retinal telangiectasias, and the new hemorrhage right eye was actually the secondary neovascularization, which was causing the vision change. So this patient had type 2 macular telangiectasias. The right eye was the one with the neovascularization, and the left eye was the non-proliferative one. So there was some intraretinal fluid, but no neovascularization. The patient was started on the anti-VEGF injections. And after a single injection, he responded very well, and the fluid significantly improved. We have to remember that the use of anti-VEGF injection in macular telangiectasia-associated neovascularization is off-label, so we have to discuss that with the patient. So learning point here, the type 2 Mactel, first of all, it's debatable whether they have the true cystoid macular edema, true fluid or atrophy, because on angiography, it's not associated with leakage. And for the dry stages, like when they only have hyporeflective spaces in the retina, but no neovascularization, no treatment is considered beneficial, so we monitor them. But once they develop neovascularization, like the right eye of our patient, they are offered the anti-VEGF injection, and many of them respond. We have to respond that the neovascularization in this condition is coming from retina, it's not coming from choroid. So if you're looking for signs which you see in typical wet macular degeneration, you will not find them. The retinal pigment epithelium is going to be smooth and intact in many patients. So what will be your clues that the patient has a secondary neovascularization? Sudden worsening of intraretinal fluid, appearance of subretinal fluid, appearance of retinal heme, like in our patient, and then FA can reveal the neovascularization, but it is not needed for diagnosis. And then treatment does not always help, but it should be offered because in many patients, it can prevent the disciform scarring and loss of vision. So this is our case 4. The case is, if it is only dry macular degeneration, why am I monitoring it regularly? The patient, I cannot do anything for the patient. At least till a year ago, now we do have treatment. So this is a patient, a 78-year-old, being monitored for dry macular degeneration. So as we can see here, over 3 years, he's gradually progressing to geographic atrophy. This is his scan in 2021, this is in 2024, and it's mostly dry. There is a small pigment epithelium detachment here, but otherwise it was completely dry. We can see on the autofluorescence there is loss of tissue going on. So he presented with a sudden vision change in the left eye, and we noticed that he has a significant worsening of his pigment epithelium detachment with some subretinal fluid and lot of intraretinal fluid. So he did convert into wet macular degeneration. He was started on the anti-VEGF injection, and he could not come for the first appointment which was given to him. So he came back 2 months later, and this is significant worsening here. So if you compare it to our first patient who over 2 months the SRF did not change, this is a rapidly progressive membrane because you see that it is getting worse and worse. But there was very good response. After a single injection, he responded very well, and then he kept on responding. So what I wanted to talk here is something which we call nascent GA, nascent geographic atrophy. This is an OCT sign preceding the development of the atrophy, the drusen-associated atrophy, which is characterized by the loss of the outer plexiform layer and inner nuclear layer. So there is a collapse of layers like you see here. And there is a hyporeflective wedge-shaped band inside the outer plexiform layer. So there are some studies which have shown that nascent GA may precede the development of type 3 macular neovascularization. And the long-term visual prognosis in these eyes, even after they are treated with anti-VEGF injection, is worse compared to other types of wet ARMD. So it is very important to start the treatment on time. If the treatment gets delayed, they can develop significant fibrosis. So that's why it is important to follow these patients when they are going from dry macular degeneration to geographic atrophy stage. And again, do not forget to monitor the other eye. This patient has similar condition in the right eye, and there is a small pigment epithelium detachment right next to the geographic atrophy in the right eye too, which we are monitoring. Okay, we are almost at the middle of it. So next case is, I have so many options of anti-VEGF agents now, then why can't I make this macula dry? So this is an 81-year-old gentleman who presented with sudden onset decreased vision in the left eye. He was diagnosed as wet macular degeneration. So we started him on Avastin. And after 6 weeks of 6 monthly injections of Avastin, there was no response. So then we switched him to Eylea, and again we started Q4 weeks. And even though there was like some response, this is on Avastin, no change at all. After Eylea, he did respond, but still there was significant fluid. So then we had a discussion with the patient, and we switched the patient to Vabysmo, the new one, the faricimab, Q4 weeks for time 6, and he had much better response. The fluid is almost dry, even though there was some fluid still left, but he was doing pretty good, vision was good. So we discussed extending Vabysmo to 6 weeks because it's the agent which we like extending after the first few injections. So when we extended it to Q6 weeks, the fluid came back. So the decision was after a single 6-week injection, when we saw that the fluid was coming back, we cut down the frequency back to Q4 weeks. After that, this patient kept on receiving Q4 weeks Vabysmo with no change. The fluid did not worsen, the fluid did not improve, but it just stayed same. Then we decided to try Eylea HD. Now we have so many agents, so the patient was switched to Eylea HD Q4 weeks. And he received many injections of Eylea HD, but same condition. The fluid just stayed stable. No worsening, no improvement. So at this time, the patient is continuing Q4-week Eylea HD injections. Ideally, with these agents, we like extending after the first 3 to 4 monthly injection. But the point I'm trying to make here is there are a lot of patients where you keep injecting and the fluid does not improve. As long as they are maintaining their vision, we have two choices. We can start extending regardless, and try to find a frequency where we can keep the disease stable on the minimum frequency. Or we can continue injecting 4 weeks. This patient decided to continue Q4-week injection with Eylea HD, so we are still continuing it, but this is a discussion which we need to have with our patient. So the learning point here, now we have two agents, Eylea HD and Vabysmo, which are approved for extended treatment interval, the FDA, approved by FDA. But are they sufficient? Our patient received 26 injections in a period of approximately 28 months, and he was very compliant. And out of those injections, 14 were Vabysmo and Eylea HD, which are the new agents, but the SRF was still persistent. So the presence of subretinal fluid on the OCT scan is generally used as a marker for the disease activity and need for continued treatment. But some patient can tolerate SRF for long periods of time without any vision change, and it is okay to monitor them either on the same frequency or still trying to extend as tolerated. Okay. So the next case is kind of highlighting the same point in a different patient. Does every bit of fluid need to be treated? Yes.
In a case like that, that's refractory to treatment, you do an FA?
Yes, we actually, I did not include the FA here to keep the presentation short, but we did do the FA. And that's a very important point, because before we decide to start extending the interval, even though fluid is still present, or we decide to stop the treatment, we always like to do an angiography to make sure that there is no active membrane which is still present. And the decision to extend or stop the treatment is only made when there is no active leakage. So the membrane is kind of inactive, but the fluid is still present. So this is a 90 years old male diagnosed as wet macular degeneration. So we can see some fluid here, which is also here. And then the patient was started on first Avastin, kind of similar to the last case. No response, Eylea, no response, Vabysmo, no response. And then though the SRF improved, it never completely went away. He still had right under the fovea. The patient ultimately, this patient, when we did the FA, no active leakage, we had a discussion with the patient to continue versus stop the injection. This patient opted to stop any further injection, and we have been monitoring him since then. His last injection was here in September 2024, and since then he has been stable and his vision has been maintained at 20/30. So same point, we don't need to treat every bit of fluid. And then sometimes we believe that not all the hyperreflective areas on OCT may signify fluid or an active membrane. They may represent tissue atrophy, and we don't need to treat them. So if it is agreeable with the patient, it's a good option to kind of stop the injection, monitor the patient, and see if the fluid is getting worse or not without the injections. We are doing okay? Am I going too fast? Or? Okay. Because we are like last 4 cases. So, okay, case 7 and 8, they kind of highlight the same point. Can I or could I have saved the other eye? So this is a patient who presented, this is a patient, 78 years old male, who had a superior branch retinal vein occlusion, which luckily was in the superior part. Like we can see here, there is a sclerosed vessel here, and it did not affect the macula. So his vision was 20/20, and now he comes with a new blurry vision in the left eye, and he's noted to have a branch retinal vein occlusion in the left eye. And I just wanted to say, like, incidentally, this patient had myelinated nerve fiber around the nerve head. This is the scan of the right eye. Because the BR view was superior, he never developed macular edema. And this is the left eye, which is the new one. And he was started on anti-VEGF injections. But before we discuss this case, I would like to bring another case here. This was another patient who had a central retinal vein occlusion in the right eye, and despite receiving multiple injections, he went on developing severe exudation, subretinal and intraretinal, and there was significant vision loss in the right eye. We never understood the reason of so much exudation. I mean, if I look at this eye alone, I would say, I mean, there was not just the component of vascular occlusion, there was some retinal vascular abnormality going on, like Coates disease, VHL, but we didn't find anything on angiography. Then this patient came back with a new BRVO in the left eye, and that blurry vision in the left eye. So I was trying to make the same point here, like it is very important to do systemic review for retinal diseases, and these patients with retinal vein occlusion, we know of the common risk factors like age, diabetes, hypertension, but it is also important to ask them about smoking. I have seen many patients who are active smokers, and they develop retinal ischemic diseases. It could be like a PDR-like picture when they don't have any diabetes. It could be vascular occlusions, but go over them again regarding the need to quit smoking. Obstructive sleep apnea can cause vascular occlusions, so refer these patients for sleep study. Establish them with a primary care physician if they are not already established. Glaucoma can cause vein occlusion, so we try to do a glaucoma workup in these patients. And then vasculitis can cause multiple vein occlusions, so it is important to do an infectious and immune workup in these patients. And then systemic medications. Patients who are on oral contraceptives or hormonal medications can also develop vein occlusions. And then we need to do some lab testing for these patients. Protein CNS, homocysteine level, vitamin B12, which is the deficiency can be common because of their dietary preferences, factor V Leiden, anticardiolipin antibodies, and CBC. So we ordered this entire workup in both of our patients, and the entire workup came negative, except for in the first patient, there was a homocysteine level of borderline high, 15.5, and B12 borderline low. And similar thing for the other patient. This was a patient with severe exudation. We ordered a big workup for him, but nothing came positive, except for homocysteine, which is within the normal level, but borderline high. So both of these patients were referred to the primary care physician for management of hyperhomocysteinemia. But the point is, have low threshold for ordering these tests. So the question here can be, I mean, the patient now has bilateral occlusions anyway, so what are we trying to save? So we have to remember that hyperhomocysteinemia is also a risk factor for ischemic heart disease and stroke. So if you find it and the patient is managed, we are saving the life of the patient also. So this is one of the important one. And then it has been found to be an independent risk factor, especially in people who are vegetarian. The deficiency of B12 can cause high homocysteine levels, and it can lead to all of these forms. So especially in the people who are presenting with ischemic forms, bilateral disease, or severe retinal vein occlusion, like our first patient who has severe exudation for no obvious reason, it is a good idea to order a systemic workup. Our last two cases are more based on neuro-ophthalmology. So this is what this is what I used to feel most afraid of when a patient is referred to you as a retina specialist and patient has like desk edema. We are like, oh my gosh, what do we do now? So I tried to make a cheat sheet for myself so I can survive those patients. And to go over that, I would first want to know, like, any guesses which of these is true disc edema and which of this is pseudo disc edema? So the top two patients, they had true disc edema, and the last two scans, they did have pseudo disc edema. So if we are talking about disc edema, there can be a lot of causes, but generally the ones which are related to retinal diseases, most important is atypical optic neuritis. Before referring the patient to neuro-ophthalmology, we should make sure that the patient does not have an infection or immune disease, which is causing the disc edema. And then in the ischemic variety, the giant cell arteritis is one we cannot miss. So if the patient is above a certain age, or if there is signs of choroidal ischemia, it's always a good idea to order ESR and CRP and CBC, very simple tests, but make sure that the patient does not have that. And there can be many cases with silent GCA where they will not have any symptoms, but they will still have temporal arteritis. And then these patients, the pseudodisc edema, malignant hypertension, papillopathy, they are also within the retinal specialists, but they are not as common. So as long as we can rule out atypical optic neuritis and giant cell arteritis, I think we'll be pretty safe. And this is the cheat sheet which is available in the books, but it helps me. I keep it with me. So how do we know that this is not a typical optic neuritis, neuro-ophthalmology field disc edema versus atypical neuritis, which can be related to retinal diseases? If the patient is a male, if there are extremes of age, bilateral presentation, no pain with eye movement, severe vision loss, and instead of bilateral, it could be highly asymmetric disc edema. And then this is very important. If it is a florid disc edema, especially associated with peripapillary hemorrhages, cotton wool spot, or exudates, always think of retinal diseases. Always rule them out instead of thinking of a typical demyelinating optic neuritis. So these are our two cases. The first one, this is a 44-year-old male. He presented with 10 days of left eye blurry vision. On exam, he did have significant disc edema in the left eye. The right eye was okay. The vision in the left eye was 20/60. Color vision was decreased. RAPD was present. And then there was a paracentral defect on visual field. So these are the 5 things. Whenever I see a patient with disc edema, these are the 5 things which I always look for to make a diagnosis. Like, first of all, we have to decide if it is true disc edema, true optic neuropathy, or just a pseudo disc edema. So this is very helpful. So then we did a OCT nerve scan, and the patient did have significant disc edema. We can see the numbers are very high. I'm still not like having hard time. So since this was atypical presentation, it was a male, and then there are hemorrhages and exudates. I think they are visible. There is a hem here, and there are 2 or 3 streaks of hard exudates in the macula. So we did decide to order a workup for him, and broad workup was ordered. And we like to do MRI in these patients, so it was normal, negative for any optic nerve enhancement. And the rest of the workup came negative. So we ordered infectious workup, T. pallidum, quantiferon, Bartonella, Toxoplasma, Toxocara, everything came negative. And we did order immune workup, the sarcoidosis. This is infectious, but we did order the other workup and everything came negative. Now, when we were taking the history of the patient said that he had pet cats. And the exam finding, they kind of look like neuroretinitis when there is disc edema along with macular edema. So he was empirically started on doxycycline 100 milligram twice daily and monitored closely. Since we didn't know what else the disc edema is coming from, we decided to monitor him and start him on the antibiotic. So 2 weeks later, he improved. His vision improved, his edema came down, and then he completed the course of the antibiotic, and his vision kept on improving. So this was interesting. I still don't know if he had cat scratch disease or not, but the patient was happy, so we were happy. This was a very interesting patient who presented recently. So this is a 41-year-old male who presented with central vision loss in the right eye for 8 weeks. His vision was 21/50 in the right eye, 20/20 in the left. He was high BMI, 35. And on the review of systems, he reported 40-pound weight loss over last few months, loss of hair and soreness in back of throat. So it was vague. It didn't point to a diagnosis. He lives with his girlfriend, has a pet cat. So this was his fundus picture. So we do see that there is significant disc edema in the right eye, and there were some hemorrhages, associated hemorrhages. There was very subtle disc edema in the left eye, but it was highly asymmetric. And then this eye is 21/50, this is 20/20. The eyes were quiet except for trace capes, which were not like true capes, but some pigment on the corneal endothelium. And then he had these ill-defined yellow lesions in the choroid. Even though the vitreous was completely quiet, there was no vasculitis, but there were some yellow choroidal lesions which we didn't know what they were. Disc edema was pretty significant. We can see the right eye is all over the place. The left eye also has subtle disc edema, even though it's very hard to see on the fundus photo. The visual field reveals some altitudinal defects in the right eye. The left eye had some non-specific points. Wow. So we made a very broad differential diagnosis in this patient. So we always try to rule out the compressive optic neuropathy. The MRI came normal. So since this patient had high BMI and that was after losing like 40 pounds weight, we were thinking of idiopathic intracranial hypertension. So the patient, we placed a neurology consult for lumbar puncture. The patient did have a pet cat, though he said that his cat didn't scratch, but it was on our differential diagnosis. So we ordered ESR and CRP. This patient was 41-year-old, but we still ordered ESR and CRP because of atypical presentation, and they came super high. So giant cell arteritis was on our differential diagnosis. And then since the patient didn't have any known diabetes or hypertension, but because of the high body weight, we reordered the tests. They were done a year before because we were thinking of non-arthritic ischemic optic neuropathy given the systemic risk factors. So these were the findings. The MRI came and of course we ordered a big infectious workup, which we always do. So the MRI came normal. For the infectious workup, the TB, Bartonella came negative. The sleep study came normal. ESR, CRP were high, so we got a temporal artery biopsy done for him, and it came out to be negative. And the lumbar puncture, the opening pressure was high, but other than that, some WBCs, but it was negative for RPR. But the patient did have a positive treponemal antibody and the RPR, high RPR. And then we sent for a HIV test, and the HIV screen came came positive. So he was started on IV penicillin for suspected neurosyphilis, and he was also started on oral antiretrovirals. After receiving the course of IV penicillin, his vision improved significantly. He came down from 2150 to 2040. And this is his disc edema just 2 to 3 weeks after he completed the course. So the right eye has come down, the left eye is now within the normal limits, and the fundus picture. So these yellow lesions, which were there in the choroid, they disappeared. Like his choroid and retina looked completely quiet. The disc edema has gone down significantly, and the capes on the cornea also discovered. So learning point, whenever we are dealing of atypical optic neuritis or neuroretinitis, we cannot miss the infections. Always order the infectious workup. Even though the social history may not suggest it, but it is always a good idea to order broad workup, including syphilis, Bartonella, TB, toxoplasma, Lyme disease, and then look for subtle signs of intraocular inflammation in these eyes, like capes, iritis, vitritis, or chorioretinitis. And order broad workup. This is generally the workup which we use for our patients who come with atypical optic neuritis. That's it. I'm here for any questions. And this is our team. Yes.
So, speaking about the vein occlusions.
Yes.
You have a patient with very obvious systemic hypertension. Do you still do a significant workup, or how soon do you start anti-VEGF treatment?
So we start anti-VEGF treatment if the vein occlusion is associated with macular edema or neovascularization. So if we see cystoid macular edema, we like to start it as soon as possible. we give the patient option to start the treatment as soon as possible. Regarding the systemic workup, if the patient has obvious risk factors like high blood sugar, especially high blood pressure, I would say we go by the age or the other signs. If it's a patient like more than 60 years and they have systemic uncontrolled risk factors, then we would not order a broad workup. But if he's systemically well controlled, he has hypertension, but it is well controlled, young patient, severe presentation, more exudation than you would otherwise think, no response to the treatment, then we do order a systemic workup. Okay.
I don't know if this works. Rather than mess with this microphone, we do have a couple of minutes before our scheduled break time. I express my gratitude both to Dr. Davis and to Dr. Gupta for their excellent presentations. But if there are any questions here, Dr. Davis has agreed to be gracious enough to address any questions from the group. I'm available, or of course, Dr. Gupta here. If there are any questions for us, please let us know, and we'll be happy to address them.
Well, thank you, everyone.